So this BPD chapter I've taken from Cloherty. So what is bronchopulmonary dysplasia or chronic lung disease of prematurity is, what definition we have taken is the old definition, okay, the 2001 definition, okay, that we are still following, but updated definition has come, okay. So updated definition that has come is 2016 NICHD workshop. They have given an updated classification of BPD. Okay, so when was BPD I first identified? Was at around 50 years before, because of inadvertent use of oxygen and ventilation strategies. They used to see very badly damaged lung. Though the children used to survive the respiratory abnormality, they used to be left with severe pulmonary or respiratory morbidity. So that condition was named as bronchopulmonary dysplasia. Who named it? Northway named it. Okay, William Northway is the person who named, who defined the term. Northway. Okay, so you just remember this name. Northway coined the term BPD. So after he gave this definition, so Banklari is one who gave the classification of BPD. Okay, so in 2001 they have given the BPD definition. So what BPD definition they follow, or the chronic lung disease prematurity would they follow? They used to follow till now is two classification. One is any infant who is less than 32 weeks. Another one is any infant who is more than 32 weeks. So if the infant is less than 32 weeks, what is the cross section when you have to label the child as BPDs? You have to wait till the child is 36 weeks. Till the child is 36 weeks post-menstrual age. So at 36 weeks, you have to see what is the child's condition. If the child doesn't require any oxygen requirement, then it is called mild BPD. So when you have to label, so the child should have received supplemental oxygen. So any other child you should not label. The child should have received supplemental oxygen in the first 28 days of their life. Okay. So if they have received oxygen, then at 36 weeks, you have to assess the child. What is the oxygenation status? If the no oxygen requirement, it is called mild BPD. And if there is supplemental oxygen requirement is there less than FiO2 less than 30%, you used to call moderate BPD. More than 30% oxygen requirement or requirement of CPAP or ventilator support, you used to call it as severe BPD. Okay, this was the NICHD 2001 definition. Okay, 2001 definition. This is what is being followed till now. And for an infant who is more than 32 weeks and there is oxygen requirement for the first 28 days. Okay, if there is more than 32 weeks and first 28 days, you have to wait till 56 days of life. So that is when you have to assess the baby. Okay, so that time we have to assess what is the severity of oxygen requirement. Then you have to label. So is the audio clear now? I think so. For few, the whole audio is not clear. Is everyone able to hear me clearly, or is it still difficult? Okay. So this was the old definition that used to follow. Okay, so then they formed a workshop, and they were missing large amount of population who were on just high flow. Here only we are discussing about oxygen. What about those patients who are on headbox oxygen, those who are on CPAP, those who are on different respiratory support like heated humidified high flow nasal cannula, triple H FNC, and some are just at 25% requirement. Okay, so some have even died at around 14 days, 15 days of life. So those patients we were missing. So we were missing the whole burden of BPD. So that's why they gave a physiologic definition of BPD. Okay, so physiologic definition of BPD was suggested in 2016. So again, they have maintained the same thing, less than 32 weeks and more than 32 weeks. Same thing they have maintained. What they suggest is, exactly at 36 weeks, you have to assess the FiO2 level requirement. Same, everything is same. Okay, for more than 3 consecutive days, what is the oxygen requirement? What is the FiO2 requirement for more than or equal to 3 consecutive days to maintain saturation between 90 to 95%? So this is called your oxygen challenge test. Okay, what is the level of support that is required to maintain an oxygen saturation of 90 to 95%? When you have to assess, same thing. If the child is less than 32 weeks, you have to assess at 36 weeks. And if the child is more than 32 weeks, you have to assess at 56 days of life. So then they have graded. There they have given as mild, moderate, severe. Currently they have graded as grade 1, 2, 3, and 3A is an additional grade. Okay. If the child is on invasive mechanical ventilation, so it cannot come on grade 1. It will always be either in grade 2 or grade 3. If there is FiO2 requirement of 21%, it is grade 2. If the FiO2 requirement is more than 21%, it is grade 3. Similarly, on different respiratory support, they have classified into different. Okay. Grade 3 comes only in your invasive mechanical ventilation or in your CPAP or NIPPV. Just nasal cannula and hood oxygen and nasal cannula of flow less than 1 liter per minute, they all come in grade 1 and 2 BPD only. Okay. So they won't come in grade 3 BPD. Okay. And another thing is 3A. 3A is another additional BPD that they have classified, and they have included those children who have died between 14 days and to 36 weeks. So in between, some children, some child has expired at around 20 days of life, at around 25 days of life. And that child had persistent parenchymal lung disease and respiratory failure. And that child, if they have assumed that if this child would have survived, that would have matched any of these BPD. So it would have landed in any of these BPD, and the child should not have died because of NEC or IVH or other episodes of sepsis. Purely, it should be a persistent parenchymal lung disease, and the child had only respiratory failure. Only the child is intubated or sick only because of respiratory failure, and the child has died between the time of assessment. Your time of assessment is 36 weeks. In between, if the child has died, then you label it as 3A. 3A BPD that child can be labeled as 3A BPD, and that will add on to your annual census of your institute or your annual census of your NICU, so that you can get a morbidity at least denominator or a number of BPD cases in your center. If there are many deaths in this age group, you will be missing most of your BPD your data. So that's why this additional 3A has been included. The rest everything is same. Less than 32 weeks, 36 post-menstrual age. More than 32 weeks at 56 days of post-menstrual age. And what is the status? What is the level of respiratory support that is required for 3 consecutive days? It is not at one time assessment. It is 3 consecutive days to maintain an oxygen saturation of 90 to 95%. So this is called your physiological definition of BPD, or a recent 2016 NICHD definition of BPD. Okay. So otherwise, operationally, what some people define BPD as just requirement of oxygen at 36 weeks post-menstrual age. Okay. And lung parenchyma should look abnormal on chest radiograph. Okay. And this is not applied only to preterm babies. This definition you can apply even to term babies also, who are like meconium aspiration syndrome, or others post cardiac surgery, or any other GA anomaly like your gastroschisis repair, or some other duodenal atresia or ileal atresia surgery, and he has been oxygen dependent chronically in your NICU. Some babies may be staying for 2 months, 3 months and all. You can even label those babies as BPD according to the day cutoff. If the baby is more than 32 weeks, at 56 days also, if the baby is oxygen requirement, rest everything is fine, you can label that BPD, that child as a BPD. Okay. And what does BPD signify? BPD is associated with chronic respiratory morbidity. Okay. The child may have chronic requirement of your bronchodilators or your respiratory support, or any use of pulmonary medications like bronchodilators and recurrent hospital admissions. So that is what is known as chronic respiratory morbidity. So I hope the definition of BPD is clear. This is very difficult definition to understand. If you understand this definition and when to label as BPD, so most of the thing is clear in this chapter. Okay. So this is what you should remember. Okay. Old definition is just requirement of oxygen. Then there is this 2001 definition, mild, moderate, severe. Then this 2016, they have this is called physiological definition of BPD, where what is for 3 consecutive days they will assess what is the requirement of FiO2 support or your level of respiratory support to maintain oxygen saturation 90 to 95%. 1, 2, 3, and 3A. You need not remember everything inside. Just remember roughly that this is the new modification of BPD definition. Okay. So what is the epidemiology of BPD is? Around 10,000 to 15,000 cases occur in US, but most often the BPD is seen in less gestational age. The lesser the gestational age and lesser is the birth weight, more is the rate of incidence of BPD. Okay, around they have given less than 28 weeks, 35 to 50%, whereas in UK, US and all, 23, 24 weeks children are surviving, and in those children around 80% they have BPD. Okay, there will be oxygen requirement at 36 weeks post-menstrual age. Okay, so coming to your pathophysiology or etiology and etiopathophysiciology. So first thing should be underlying extreme prematurity should be there. And there will be antenatal factors and postnatal factors. What are the antenatal factors? There should be IUGR and placental dysfunction. Or if there is a chorioamnionitis and the baby is delivered premature, there may be, this is all underlying setting on which the BPD occurs. So there is an IUGR baby, there is a placental dysfunction, chorioamnionitis, or antenatal bacterial colonization of the lung, and maternal hypertension, preeclampsia, drugs, genetic predisposition, maternal smoking. So all this will predispose to a premature baby who is born. And there will be, what if the premature baby is born at 27 weeks, 28 weeks, there will be definitely lung will be still in a developing stage, and there will be developmental arrest that occurs. For example, in a saccular stage or a canalicular stage, the lung will be there only in that developmental stage only. And then there will be, what will be happening postnatally, you will be intubating the baby, you will be ventilating the baby, so you will be giving inadvertent oxygen, you will be causing infection, sepsis in the NICU, there may be PDA and more flooding of pulmonary circulation. There will be baby will be keeping NPO, prolonged nutritional deficiencies. So all these things, what will cause is, it will cause lung injury, it will cause developmental arrest of the lung, it will cause vascular damage of the lung, and number of alveoli and capillaries are decreased in the lung. So when there is already a premature baby with this setting, you will be damaging and postnatally, and already there is a setting antenatally in that baby, then this will cause your respiratory failure. And also there will be underlying pulmonary hypertension in almost all BPD patients. Okay. So what happens is, if the baby is very sick, there will be death of that baby. There will be early respiratory death, and that baby may qualify for type 3A, grade 3A, or he may even expire early also. And somehow the baby survives, and there will be repair occurring in the lung or regeneration of the lung tissue. And sometimes if there is adequate nutrition you supply and all, there may be complete resolution within like 3 weeks, 4 weeks, there will be disease resolution. Suppose there is a inadvertent repair, abnormal repair, abnormally the lung has repaired, and there is prolonged nutrition deficiencies, that child will go in for your BPD. So the abnormal repair that has occurred to a damaged lung or an arrested lung development with underlying airway vascular damage, a number of capillaries are decreased. If there is inadvertent repair, that baby will go in for BPD. Okay. So this pathophysiology diagram you have to write into your exam. Okay, antenatal factors, postnatal factors, and then there is lung injury. And child may present to you with respiratory failure and pulmonary hypertension. If there is early respiratory death, the child is gone. If the child survives and there is repair or regeneration, controlled repair or regeneration, it will cause disease resolution and baby will be normal. If there is prolonged requirement of oxygen, inadvertent repair by the body, and abnormal repair or regeneration of the lung tissue, it will lead to BPD. Okay. So as I told, what are the antenatal factors? There should be an underlying prematurity setting and low birth weight. So prematurity and low birth weight are the most important risk factors. 80%, 22 to 24 weeks, 80% incidence. Whereas more than 28 weeks gestation or at 28 weeks, only 20% may develop BPD. Okay. There should be underlying genetic factors have been identified, and intrauterine infections, chorioamnionitis, all this will cause cytokine release and will cause BPD. Okay, ureaplasma ureolyticum has been associated with BPD, and chlamydia trachomatis and other viral infections, intrauterine chlamydia trachomatis infection and other viral infections have also been implicated. And intrauterine growth restriction also been associated. Okay, so these are the antenatal settings you have to remember. You can just remember this name. And same things has been given. Once the baby is born, because the baby is small and gets intubated, and you cause volute trauma, lung injury, and you do inadvertent bag and mask ventilation, inadvertent oxygen use. Okay, so there will be insufficient antioxidants system in the child or a preterm. So this will cause oxygen toxicity. Okay. and excessive intravenous fluid administration lead to pulmonary edema. And PDA, persistently open PDA, it will cause left to right shunt. And lung microbiome and lung dysbiosis has also been linked recently. Lack of early feeding, lack of initiation of breastfeeding, and so these are all been implicated. So what is the pathophysiology? This is how the setting or etiology of the BPD. So what is the pathophysiology is there will be acute phase and a chronic phase. Okay. So what will be occurring during acute phase? There will be lung injury that will be occurring during acute phase. Whenever there is oxygen toxicity, barotrauma and volutrauma, when you stretch the lung, the alveolar epithelium is stretched and it is damaged from the mechanical ventilation. If you don't do gentle ventilation, if you don't give surfactant, if you don't gently ventilate the baby, or you don't manage the baby with non-invasive ventilatory support for every respiratory distress, if you keep on intubating, there will be alveolar cellular injury and interstitial injury that will be occurring. That will release your cytokines, and that will cause alveolar permeability will be increased, and that will recruit the inflammatory cells, and that will inflammatory cells will release the proteases, and that will cause inflammatory leakage of water into the alveoli and the interstitium, and this will cause your alveolar damage. Simultaneously, the airway and vascular tone also may be altered. What will happen is your all sloughed cells and secretions will get accumulated, and that will prevent your mucociliary transport, and that will cause an alternating areas of collapse and hyperinflation. There may be smaller airway obstruction, or there may be some areas there may be air trapping and emphysematous changes also. Okay, so what definition they have given is two things. There is old BPD and new BPD. Old BPD is this used to occur pre-surfactant era. The smaller babies, they never used to survive in that era. Preterm babies who require surfactant, they never used to survive before surfactant. Only the older babies used to survive, like 2 kgs, above 34 weeks they used to survive. Only those babies, this kind of BPD will be seen. That is characteristically associated with small airway injury, fibrosis, and emphysema. There will be dense fibrous bands in the lung, emphysematous changes in the lung, but still it is seen in developed countries. It is seen in the underdeveloped countries where ventilation strategies are not appropriate. So whereas in developed countries like US and other things like Scandinavian countries, BPD is seen only in the extreme preterm babies, to less than 25 weeks, 24 weeks, you see BPD. Whereas older babies, more than 28 weeks and all, you will never see BPD in those countries. Okay. So what happened after surfactant therapy era is only extremely preterm babies, you see the BPD changes. Whereas here what you will see is, if you see the pathology of or a lung sample, lung biopsy or autopsy sample, what you see is decreased alveolarization, fewer simplified alveoli. Some are large alveoli. There is no septation. The alveoli, the baby has gone even before the septation has started in the alveoli. And there is decreased vascular development. You don't see much fibrosis in nowadays BPD. Okay, in the new BPD era, you don't see the fibrosis and the emphysematous changes which you used to see in the old BPD time. Now you see simplified, larger alveoli and decreased pulmonary vascular development. So this is what the finding of new BPD. Whereas old BPD, smaller airway injury, fibrosis, emphysema. So this is the definition. This is the difference which you should know. Okay. So what happens once the lung injury has happened? So there is already this lung injury has happened. So what happens in chronic phases? So chronic phase, there will be fibrosis, there will be repair. The lung injury has happened. The body is trying to repair in your chronic phase. Okay. So there will be dysregulated repair. So that is what which leads to BPD. If there is a regulated repair, you are supplying the nutrients, you are controlling the inflammation, you are controlling the sepsis, you are giving adequately fluid control. So all these things will lead to regulated repair, and the baby will recover from your injury, whatever injury has occurred. To some extent, it will recover. If you still continue to injure the lung, so it will lead to dysregulated repair. Okay. So when there is dysregulated repair, it will lead to an established BPD change. Okay. So what happens is the interstitial fluid clearance will be disrupted, and there will be pulmonary fluid retention, pulmonary edema, persistent crackles in the lung, and the airway develop muscularization and hyperreactivity. Just like your asthma, the baby will have muscularized your smaller airways, and there will be hyperreactivity of the airways, and the baby may have BPD spells. We call it as BPD spells here. And this will lead to your decreased lung compliance, increased resistance, impaired gas exchange, and resulting in ventilation perfusion mismatching and air trapping. This almost behaves like your asthma. So asthma, just like your asthma, here there will be airway hyperreactivity occurring during a chronic phase. In acute phase, what you see is an injury. After that, dysregulated repair is your chronic phase, where the airway muscularity will increase, hyperreactivity will increase, and the baby may have BPD spells. Okay. So next is pulmonary hypertension and arrest of alveolarization are seen. That already I have told. So pulmonary hypertension is mainly related to vascular changes. Okay. So most of the patients, 25 to 40% of your BPD patients will have pulmonary hypertension. Okay. Why this happens is just like your lung growth is abnormal, alveolar growth is abnormal, there will be lung vascular growth also will be impaired. Okay. Just like pulmonary growth, vascular growth will also be impaired. Okay. So this is about your etiology and pathophysiology. I hope this much is clear. So once after this class, you read about this chapter. So some of you are finding it difficult to write this chapter. That's why I took it up first in the discussion. Because if I teach at the end after a few topics, you will not be able to understand anything. So what is the presentation? As I told, the presentation of BPD is usually BPD spells. There is big persistent oxygen requirement, oxygen dependency, intermittent cyanotic and life-threatening episodes. Suddenly there will be desaturation. Suddenly there will be bronchoconstriction, no air entry occurring bilaterally. Suddenly baby who has oxygen requirement in your NICU, suddenly he will become cyanotic and sudden sick. You will think that the baby has collapsed or something has happened, pneumothorax has happened. So these are all BPD spells that will occur. Okay, these are airway hyperreactivity. And examination you do, we will have tachypnea, retractions, and rales on auscultation. Rales mainly because of increased interstitial fluid. The fluid will not be able to clear properly. So arterial blood gas, if you see, there may be chronic CO2 retention, and there will be metabolic compensation also. So there may be metabolic alkalosis for chronic respiratory acidosis. So this is the arterial blood gas picture of a BPD baby. Chest radiograph, if you do new BPD, only there will be haziness. So diffuse haziness of the lung. You think the sepsis is not clearing. Okay. And there will be increased density and lung volume may be normal or low. There will be simplified alveoli. So there may be some fluid in the interstitium that will be causing diffuse haziness. Whereas in severe disease, as I told, it may occur like an old BPD also. There may be opacification, hyperlucency, and superimposed hyperinflation, like emphysematous changes can also be seen in severe disease. Okay, if there is only diffuse haziness, you can think it like a new BPD. If there is more opacification, there may be bands that may be seen, and hyperinflation, some areas are seen, then it may resemble like a old BPD. So always you should do echocardiography and ECG evaluation to look for any cardiac dysfunction or any other cardiac abnormality or pulmonary hypertension should always be done. Some Western countries, they do even pulmonary function test also. So next is, how do you manage a baby with BPD? So this is after knowing how BPD happens and what is the clinical presentation. How do you manage a BPD? So always you should think of preventing a BPD rather than treatment of BPD. There is no proven treatment for BPD. It has to repair on its own, and it will take its own course. So what you should always remember is there is no proven treatment for BPD. So all interventions are for prevention of BPD. Whatever you give in your NICU, like even some are using vitamin A or steroids, but everything, these are all not treatment of BPD. These are all just to symptomatically control the symptoms of BPD. Okay, so there is no proven treatment for BPD. So goal of treatment during the NICU care is to prevent and minimize the further lung injury. So what you should prevent is prevent barotrauma, volutrauma, oxygen toxicity, inflammation, and you should maximize the nutrition and you should diminish the oxygen consumption. Okay, always do not give inherent oxygen, control your saturation between 90 to 95% only. So there is no treatment for BPD, only prevention. So what are the preventive things that are proven is pharmacological prevention. Another one is ventilation prevention. How do you prevent by ventilation? And how do you prevent pharmacologically? Pharmacologically, there are some proven roles like vitamin A. That also IM vitamin A 3 times a week for first 28 days of age. Already your baby has a BPD, there is no proven role. Only during acute injury phase. Okay, this is during acute injury phase, I'm telling, not during your chronic phase that has to be given vitamin D. Okay, so this usually reduces the incidence in 10%, just 10% reduction even with use of vitamin A. So only one trial has used oral vitamin A. Only based on one trial, we cannot give an effective treatment. Okay, oral vitamin A is available only in India. There's IM vitamin A is not available in India, so we cannot use vitamin A. Okay, and there is no long-term impact. Okay, when the caffeine, early caffeine should be given as soon as possible, less than 3 days, based on the CAP trial. As soon as possible, we have to give caffeine. Okay, so within recent evidence suggested beginning caffeine therapy within first 72 hours of age, and higher loading and maintenance dose results in greatest reduction of BPD risk. And what about postnatal steroids? Postnatal steroids, there may be different types of steroids, like in systemic steroids and inhalational steroids. There are two types of steroids. Okay, so inhalation, systemic steroids, there are two things: dexamethasone and hydrocortisone. So dexamethasone, again, you will get early dexamethasone and late dexamethasone. Early dexamethasone is less than 7 days, and late dexamethasone is more than 7 days. Okay, so this has early dexamethasone has resulted in better respiratory parameters, but it is associated with very high risk of GI perforation, hypertrophic cardiomyopathy, cerebral palsy, and major neurosensory disability. So early dexamethasone is beneficial, but it is associated with higher risk, so it is not used. So it is not advised to use early dexamethasone. Whereas benefit of late dexamethasone is very, very less. Okay. So, and there are short-term side effects. When you use dexamethasone therapy for baby, there may be hyperglycemia, glycosuria, hypertension that may be occurring. Okay, so there is there are clear evidence of increased cerebral palsy if you use dexamethasone. Okay, next is hydrocortisone. So what they have used is early, within first 7 days, 7 to 10 days, they have used tapering dose of dexamethasone. Okay, so dexamethasone early, first 7 days. If you are thinking you are managing a 25 weeks baby, there is high risk of BPD. Early dexamethasone in a tapering dose has been suggested to decrease BPD risk. Inhaled steroids, not proven role. Okay, only recently they are mixing the steroids with surfactant. When you are giving surfactant, they are mixing the steroid, like budesonide has been combined with surfactant. That holds a promise in preventing BPD. Okay, what all we are talking is about prevention of BPD. Okay, so how do you use? So there are so many complications with steroids. So how do you decide which steroid to give, when to give? So what you have to use is this calculator. NICHD BPD outcome estimator is there. You have to put your baby's detail into that calculator. So what is the gestational age? What is the weight of the baby? Current respiratory, current ventilatory settings. All this thing, if you put, it will give the risk. If the risk is more than 60%, then you start DART regimen. So DART regimen you should be given only after doing this calculator, using this calculator, then only you give DART regimen. Only it has to be used in those babies who are on ventilator, not in all children. Okay. So no proven therapies, inhaled nitric oxide and use of superoxide dismutase and other drugs. There is no proven role. Insulin-like growth factor, mesenchymal stem cells, these are all still under investigation only. Or use of azithromycin to control ureaplasma and chlamydia, as I told, these are all under investigation. So these are no proven treatment. Okay. So what about mechanical ventilation? So what should be your strategy during acute phase? And what should be your strategy during chronic phase? This is very important. Okay, so always minimize the invasive ventilation. One important strategy to prevent injury by mechanical ventilation is don't use mechanical ventilation. Okay, if you're using mechanical ventilation, there should be gentle ventilation. Always try to use non-invasive positive pressure ventilation, and at least even after extubation, go for non-invasive positive pressure ventilation rather than directly going into room air or hood box oxygen. So this will prevent your extubation failure, again re-intubation, re-injury to the lungs. Okay, so HHFNC is preferable more than 28 weeks. And always use volume targeted ventilation, use sensors for ventilation, always target the tidal volume, give gentle breaths, 3 to 5 ml per kg per breath. Okay, and do blood gases to adequately titrate your ventilatory settings. And always use patient triggered breaths, and always use pressure support spontaneous breaths. These are all proven to lower BPD risk. And gentle ventilation, like you may target arterial CO2 more than 55 with pH more than 7.25. Target saturation should be 90 to 95%. And PaO2 in blood gas should be 55 to 80. Don't target more than 100 PaO2. And routine use of HFOV does not prevent BPD. Okay. And chronic phase, what you have to see is you should maintain PaCO2 less than 70. Chronic phase, the lungs are already damaged. You don't more damaged lung just because your CO2 is more than 60 and all. You don't further damage the lung. Even if you accept up to 65 to 70 CO2 also is fine, because there will be compensated respiratory acidosis. There will be metabolic alkalosis also seen in that baby. Okay. So and always use supplemental oxygen. Okay. Do not keep the baby hypoxic. And then surfactant therapy. Early surfactant therapy is very useful to prevent BPD. Always give surfactant less than 2 hours. That will improve survival without BPD compared to surfactant therapy later time. Okay. And use of milk in the NICU. This will prevent your BPD, and it will cause reduction in NEC, late onset sepsis. And your closure of PDA, hemodynamically significant PDA, should be investigated and should be closed early. And fluid management, you have to maintain sodium between 140 to 145 and limit fluid to 130 ml per kg per day if your urine output is adequate. With high calorie density, you have to restrict fluids if you're thinking BPD can occur. And medications also, you have to treat medications carefully you can use. Okay. So these are all the interventions to prevent BPD. Though nowhere they will give to treatment of BPD. Only you can control some of the symptoms by using diuretics. If there is pulmonary fluid overload, you can use diuretics. What diuretics you can use? Furosemide can be used initially. Subsequently, you can add on thiazide. If there is furosemide induced toxicity or hypocalcemia that is occurring, you can add on hydrochlorothiazide. When there are BPD spells, you can use bronchodilators. And caffeine has airway dilation effects similar to aminophylline. And steroids, there is no clear indication to give in an established BPD. Already there is an established BPD. There is no clear role of steroids. Only if there is exacerbation, just like in asthma, you can give oral steroids for very short duration, like 2-3 days, to improve the work of breathing and all. You can give steroids. And apart from that, medication for pain control you can use. And so how do you monitor is you can use ABG to see the gas exchange, and pulse oximetry. Capillary blood gas you can do instead of arterial blood gas. You can frequently do a capillary blood gas, and some centers even use transcutaneous PCO2 monitors. Okay. Nutrition, you have to give what is only thing you have to remember is nutrition. Okay. So you have to give high calorie dense food, almost 1 to 1.5 times your calorie requirement. So always use breast milk, and if there is no option to use breast milk, always next option is donor human milk. And give vitamin supplements. And the thing is blood transfusion only when HB is around 8 to 10 gram per deciliter. So these are the things like developmentally supportive care may minimize BPD risk. So pulmonary, always screen for pulmonary hypertension. As I told, with pulmonary hypertension, there is mortality risk is very high. And chronic hypoxemia will lead to right ventricular hypertrophy. There may be cor pulmonale that may be occurring in these children as early as even 1 year, 2 years. These children are prone for cor pulmonale and right ventricular failure. Okay. So even they may develop systemic hypertension also. Always screen these patients when they are coming in follow-up. Always screen for systemic hypertension also. Those patients who are requiring steroids, whom we have treated with steroids, they may be prone for systemic hypertension also. And always screen in follow-up, always screen for hearing loss because of your furosemide therapy or IV antibiotic therapy, and screen for ROP, nephrocalcinosis, osteopenia, and gastroesophageal reflux. These are all things that can be caused. And even inguinal hernia risk is seen higher in these patients. Okay. So as you see, there is no treatment. There's absolutely no treatment for BPD. Only thing you can do is prevention of BPD. Okay, so this much if you write in exam, this flowchart definition and etiology flowchart. Pathophysiology, you can make it as an acute phase and a chronic phase. And in chronic phase, there will be arrest of vascularization and pulmonary hypertension, clinical presentation, and treatment. Treatment, you have to mainly discuss on prevention. And established BPD, only thing you can do is can use sometimes Lasix to prevent fluid overload. If there's already fluid overload, use Lasix, nutrition, adequate nutrition, and try to taper oxygen and screen for comorbidities. These are the things that you can do. So, any doubts you have on BPD? If you've not understood anything like what to write, this may take more time, this chapter. Don't read unnecessary things, only read the headings. Don't go much into the statistics, which is a proven evidence therapy and other things. Okay, so after this, we will discuss about the fetal therapy. So this I have taken from Nelson. So this is very well given in Nelson. Okay. So this you can get as a 10 marks question or a 5 marks short notes. Okay. So what are the fetal interventions or fetal surgeries or fetal therapy? Anything they can ask. Okay. So there are because of advent of your ultrasonography techniques, newer machines that are coming up, even fetal MRI and targeted fetal anomaly scans that you do in second trimester. There are many diagnoses that have been detected antenatally itself. So many children, you can detect so many anomalies antenatally. And there have been so many possibilities of fetal interventions that are coming up. Some of the interventions, they have proven to be beneficial to this developing infant. And some they have tried and they have abandoned it. And some they are still under investigation. Some they are still modifying the technique and they are still under investigation. And so what you should do, so over the last 3 decades, they have been able to do so many research in these fetal surgery. And why they have been able to do fetal surgery is because of advanced ultrasound, fetal MRI, fetal echocardiography. They have been able to accurately diagnose fetal disease. And past 3 decades, there have been lot of anesthesia technique that have come up, and tocolysis they have come up, and many mothers used to die because of these fetal surgery interventions. And there have been specific equipments, more expertise, and fetal care team and fetal centers, state-of-art fetal centers have come up in the last 3 decades. Okay. However, fetal surgery still remains controversial. Okay, so always there should be an ethical committee that should be taken into consideration before doing any fetal procedures. And you are handling 2 patients. Fetal surgery, usually you should consider 2 patients simultaneously, both mother and fetus. You should discuss the both risk and benefit both to the mother and to the fetus during the current and also during the future pregnancies. Also, you may be totally giving a skeletal muscle relaxant, and totally the uterus may be atonic, and the mother going for PPH, and she may be undergoing hysterectomy also. So you have to balance the risk and benefit of fetal surgery and also the risk to the mother whenever you are planning such fetal procedures. Okay. So what does International Fetal Medicine and Surgery Society tell is, so when you should do fetal surgery, which condition you should do, you have to select for fetal surgery is. So a fetal surgery candidate should be a single baby. There should not be a twin baby. Always you should do on a singleton pregnancy. There should be no other associated abnormalities on level 2 ultrasound. There should be no other major abnormality, and karyotype and should be abnormal. Okay, like karyotype, alpha fetoprotein levels, or viral cultures, they all should be normal in such babies. There should not be any torch infections. And the disease process must not be so severe that even after fetal surgery, the baby cannot be saved. And the disease process should not be so mild also that even if you leave the baby, you can do well without any requirement of therapy. The baby may do well. Okay, even you can operate postnatally. For example, mild hydronephrosis that doesn't require a fetal surgery. Okay, and the family should be well counseled, and they should understand the risks and benefits of fetal surgery, and they must be agreeing for long-term follow-up. So what had happened to the fetal surgery? Since it is a evolving branch, they should contribute to the data. They should be agreeing for long-term follow-up, and there should be a multidisciplinary team should be present. Okay. So the disease process is fatal. They should agree that the multidisciplinary team, the ethical committee, they should agree that without this fetal intervention, it is fatal. The disease is going to fatal. The child is not going to survive. For example, if there's a critical aortic stenosis, without this fetal intervention, it will lead on to hypoplastic left heart. So, and the family should understand the risk and benefit. Okay, and they should understand that they should go for fetal intervention. So the family should understand, the multidisciplinary team should be convinced that without intervention, the disease is fatal, and family should accept and the risk and benefit, and they should go for fetal intervention. So with this background, we will see what are the things that can be amenable for fetal surgery. Okay. So what is thing is obstructive uropathy and non-obstructive uropathy. These are the most common things that come in discussion. So, okay. So this table you can remember. So what are the surgeries that has been done? What is the pathophysiology and why rational for intrauterine intervention? So first thing is your congenital diaphragmatic hernia. So previously they used to operate for congenital diaphragmatic hernia. Now it is only Phytoscopic. There will be balloon insertion into trachea. So Phytoscopic tracheal occlusion they will do. So why they will do CDH surgery is if there is a CDH, it will cause pulmonary hypoplasia and it causes pulmonary hypertension. So you have to reverse the pulmonary hypoplasia and reduce the degree of pulmonary hypertension. Okay, but you will not repair the CDH intrauterine. You will just allow the lung to grow. So, okay, so you allow the lung to grow just by occluding the trachea. You will allow the fluid in the lung to retain. That will cause the pressure exertion on the lung. More pressure is exerted in the lung, more branching of alveoli will happen, and more lung will be growing. So, actual repair of CDH, you will be delayed until after birth only. So next is what is lower urinary tract obstruction. So what will cause is because of back pressure, it will cause renal damage because of obstructive uropathy. And because of the less solid amniotic fluid, it will cause pulmonary hypoplasia and Potter sequence will be happening. So, and you prevent renal failure and all, you will do a urinary diversion procedure. You will do vesicostomy, vesicoamniotic shunt and all. So you will prevent the pulmonary hypoplasia. Next is sacrococcygeal teratoma. What it will cause is it will cause high output cardiac failure because of AV and shunting within the teratoma. And direct tumor mass can cause pressure abnormality and poor fetal growth, and it may cause stretching of the uterus and it may cause preterm labor. So what you can do is reduction of the tumor. Okay, reduction or functional impact by tumor by chemoablation. Okay, we will do a chemoembolism of vasculature, that is supplying the tumor. And then is any thoracic space occupying lesion like CPAM or CPAM that will you do. Okay, if there is a space occupying lesion, it will cause hydrops due to mediastinal compression, SVC compression. So you do a space for the lung development. Okay, you do a cystoamniotic shunt and all. Next is neural tube defects. So it will cause Arnold-Chiari malformation and chronic CSF leak and hydrocephalus. So you do a repair intrauterine. Okay, so intrauterine you will do a repair in such conditions. Then cardiac malformation like critical lesions, like suppose aortic stenosis is there, mitral stenosis is there. If the blood doesn't flow in the cardiac chamber, there will be hypoplasia occurring. So to reverse that, you will do a dilation procedure intrauterine itself. Reversal of process by anatomic correction of restrictive pathology. Only the restrictive pathologies are amenable. Not all cardiac diseases are amenable. Like you don't correct an Epstein's anomaly, you don't correct the other things like TAPVC. So all these things you don't correct. Only the critical obstructive pathology lesions like aortic stenosis, interrupted aortic arch, so or mitral atresia. So all these things you will correct intrauterine. Okay, so some of the things that are done on placenta are, if there is an abnormal twin to twin transfusion that is occurring, so you may cause a laser ablation of that channels can be done. Okay, if there are amniotic bands, it may cause amputation also. Severe vascular damage can occur. So you prevent the amniotic band syndrome that may cause deformity, functional loss of limbs. So you release the amniotic bands. If there are chorioangioma, it may cause high output cardiac failure in the fetus. Then you may ablate that ablation of that chorioangioma can be done intrauterine. So there is surgery on the fetus, surgery on the placenta, cord or amniotic membrane. So these are the two things you can do. So if you remember this chart and write in exam, that is enough. Then is obstructive uropathy, as I told. So this is the fetoscopic placement of vesicoamniotic shunt. So they will do a vesicoamniotic shunt. If there is a posterior urethral valve, so if there is posterior urethral valve, they will do vesicoamniotic shunt to release the obstruction. So release hydronephrosis. Okay. So next is non-obstructive uropathy. For example, if there is a cystic kidney disease, autosomal recessive kidney disease or multicystic dysplastic kidney disease, there will be no urine forming, there will be oligohydramnios, and there will be pulmonary hypoplasia. Okay, so what they do is not for renal management. What they do is for lung maturation, they will do serial amnio infusion. Serial amnio infusion is done just for lung maturity. They will put an amni port also. So then weekly they will do amnio infusion into it. Okay. So that's how lung maturity is maintained. Only after the baby is born, the baby has to be on a dialysis long term, and then they have to plan for a renal transplant. This is done during your in Western settings. I have seen baby this being done in Norway hospital when I visited. So they have to go for dialysis and then renal transplant when the child is 2 to 3 years of age. As soon as the baby is born, they will put the baby on dialysis. Until 2 to 3 years, the baby will be on dialysis daily. And once the baby is good enough age to tolerate renal transplant, once the organ is available, they will do renal transplant at 2 to 3 years of age. Okay. So next is for CDH, what they do, as I told you, earlier they attempted to repair the CDH in utero, but they have failed it, and it has caused even maternal morbidity also. Okay. So then they withdrew the CDH repair. So what they are doing is occlusion, the tracheal occlusion of fetal trachea that causes lung growth, and it improves the lung growth, and it reduces the pulmonary hypoplasia. So this is being followed now. So fetoscopic balloon tracheal occlusion is done. When they will put balloon, it is usually put at 27 to 30 weeks, balloon is put, and again the balloon is removed at 34 weeks. Otherwise, if the delivery occurs and your balloon is there in the trachea, the baby cannot breathe. Okay. So before delivery, again a fetoscopic procedure has to be done. The balloon has to be removed. Only after the balloon is removed, then there will be alveolar type 2 cell maturation will happen. Okay. So this timing is based on the hypothesis that tracheal occlusion, lung growth will happen. And while removal of the balloon before delivery will promote alveolar type 2 cell maturation. Okay. So why balloon is placed? To cause lung maturation and lung improvement, lung growth. And why when lung is removed, after balloon is removed, there will be alveolar type 2 cell maturation will happen. Okay. Next is CPAM. If there is CPAM, what they do is they will do the cyst volume ratio they do. That is the largest cyst and the head circumference ratio they take, CVR. If the CVR ratio is less than 1.6, and what they do is if there is CVR ratio is more than 1.6, they will do intervention. That is again cystoamniotic shunt they do. Okay. Cyst to the amniotic fluid. So sometimes they have even used antenatal corticosteroids also. That may also decrease the risk of decrease the size of CPAM. So antenatal steroids also has been used. Next is myelomeningocele. So myelomeningocele repair also can be done intrauterine. So what they have seen is if the repair is done intrauterine, there is a requirement of ventriculoperitoneal shunt is less compared to postnatal repair. Okay. So 40% in intrauterine repair group and 82% in postnatal repair group. Okay, and fetal repair group had improved composite score and mental development motor function at 30 months. That's why it is improved. So what trial they have done is MOMS trial, management of meningomyelocele study. A MOMS stands for management of meningomyelocele study. So in that study, they've seen that antenatally, if you repair meningomyelocele, there is a requirement of VP shunt is less, 40% compared to 82% in postnatal repair group. Okay. So this is one of the diagram fetus showing meningomyelocele. They are repairing the meningomyelocele. They are opening the uterus and they are doing a meningomyelocele repair. Okay. So other antenatal interventions are hypoplastic left heart syndrome, aortic stenosis, pulmonary stenosis. They will all do balloon valvuloplasty. Okay. And they will dilate the vessels. For example, here they have given. So you can see 4-chamber view of the fetus. And for aortic stenosis, they are putting a balloon here. So you can see the balloon here. For aortic stenosis, they are dilating. If you don't dilate this, aortic stenosis will lead on to hypoplastic aortic arch. If there is no blood flow here, the arch would have become hypoplastic, and it will give a hypoplastic aortic arch, and the baby will collapse after birth. It is a critical congenital heart disease. Hypoplastic aortic arch is a critical congenital heart disease. So if you dilate this aortic stenosis, there will be blood flow. The flow of blood will cause growth of aorta in the intrauterine life. Okay. So next is, these are some of the amniotic bands picture. Okay. So this is one of the amniotic band, and they are releasing the amniotic band. Okay, so you may have seen the baby would without a finger or an amputated thumb in your labor room postings. These are all amniotic band syndromes. So all you need is a good fetal counseling team, and there should be a specialized equipment like exit procedure, and ECMO should be backup. There should be an ECMO backup. And these are the things that are required for a well developed fetal centers. In India only, I think they do some of the centers in Chennai. They do meningomyelocele repair, and also vesicoamniotic shunt is also being done in some of the centers in Gurgaon, and also in AIMS also they do very rarely. And there's important selection of patients for fetal repair is very important. When there is diagnostic certainty is there and prognostic certainty is there, then you should not go for surgery in these patients. Okay. For example, if there is a established diagnosis, trisomy 13 is there, 15 is there, trisomy 18 is there, you already know that the prognosis of such a child, the child will not survive beyond 1 year. So all those things, all those children, you should not operate. When there is multicystic dysplastic kidneys and you are already certain diagnosis is there and the prognosis is not very good, you should not go for surgeries. Okay. And some of the things like prognosis is uncertain, and for the best interest of the family, you have to do surgeries in these situations. Okay. For example, some cases of hypoplastic left heart syndrome and some cases of genetic problems. Already there is an inborn error of metabolism. 3-4 children, they have died. Already this child also you have diagnosed with inborn error of metabolism. So you think postnatally they are planning for liver transplant and all. In such children, you can go for fetal surgeries. Okay. So this is about fetal surgeries. You can just write what is the International Fetal Medicine and Surgical Society recommendations, and then what are the diseases that are amenable for fetal surgery, diseases for fetal surgery, and surgery on the placenta, cord, or membrane. You can divide like this and write in exam. Okay. If you know so much, then you can write for 10 marks as much as you want. Okay, this question you may get for 10 marks. This is very well given in Nelson. You can go through this chapter. So next thing what we can discuss is healthcare infections. You may get this question. So most of you don't read this chapter in Nelson. So that's why I thought I will take up this. At least you should know some things about this, and so that you can at least write in exam. Okay. So what are the healthcare infections that can occur in nursery or NICU? This question has been asked previously in RGHS, and you may get also. So healthcare associated infection you may get, or healthcare associated infection in NICU, nursery, or even pediatric group, the definition changes. So otherwise most of the definitions are same. So who are more prone for healthcare associated infection? Those infants that have prolonged hospitalization. So which infants will have prolonged hospitalization? Premature infants and very low birth weight infants, they have prolonged hospitalization, and these infants are prone for healthcare associated infection. Why they are prone for healthcare associated infection? Because they have inefficient innate immunity, they have deficient skin barriers, they all have indwelling catheters, umbilical catheters, PICC line for long time, and they have other devices like urinary catheter. There may be OG tube lying, there may be prolonged mechanical ventilation and endotracheal intubation. So all these things will predispose them for healthcare associated infection. Okay. And what is the implication of this healthcare associated infection? Again, infection causes prolonged hospital stay, and also it will increase the cost of care, and also morbidity and mortality is increased. Okay. So what is the incidence of healthcare associated infection? What are the most common healthcare associated infection is? It is central line associated bloodstream infection. The most common healthcare associated infection in NICU are bloodstream infections. That too, central line, CLABSI we call, central line associated bloodstream infection. So CLABSI is the most common. Second most common is ventilator associated pneumonia. Okay. After this, it is followed by surgical site infection or even a catheter-associated UTI, CAUTI, CAUTI. So CAUTI is catheter-associated UTI. So most common is CLABSI. CLABSI is central line associated bloodstream infection. Second most common is ventilator-associated pneumonia. After this, there is prolonged surgical site infection and catheter-associated urinary tract infection. Okay. So how many percentage of NICU patients will have healthcare-associated infection? Around 11% of NICU. This is Western data. So in India, almost 50% may, you may take it as 30 to 50% may have healthcare-associated infection if there is a prolonged hospital stay. And 25% of VLBW infants may have blood culture-prone sepsis during their hospitalization. And how much is the percentage of VAP is 25%. Out of all healthcare-associated infection, 25% is by VAP, ventilator-associated pneumonia. Okay. So what are the definitions of these healthcare-associated infection? So first you should see what is nosocomial bloodstream infection. So what do you mean by a nosocomial bloodstream infection? It means that the baby was not infected after the baby is born. After the hospital stay, after a few days in hospital stay, the baby has got a bloodstream infection. That is called a nosocomial bloodstream infection. So nosocomial bloodstream infection can be just a bloodstream infection without any central line. If there is a central line, or an umbilical line or a PICC line and all, then you call it as a central line associated bloodstream infection. Okay. So if there is just infection in the baby that is occurring, then it is nosocomial bloodstream infection. The baby has a blood culture after coming into hospital. First, so we see so many times on the day of admission, blood culture we have taken, the blood culture is sterile. After that, day 3, day 4, we send a blood culture, becomes positive. So that is a nosocomial bloodstream infection. Okay. So what is the definition is? It must meet one of the following definition. Okay, for example, there is a pathogen in one or more blood culture. Blood culture should be positive to call it as a laboratory confirmed bloodstream infection. Okay, so when it should be positive, it should be performed for clinical, diagnostic or therapeutic purposes and not related to infection at any other site. It should not be from any other site infection. It should be purely from blood. The blood should be positive. Okay. And if there is a commensal organism, it should be 2 cultures positive. If there is pathogenic or like Klebsiella or Acinetobacter and all, only 1 culture is enough to prove it as a bloodstream infection. For commensal organisms like Coans, coagulase negative staphylococci, and or viridin streptococci and all, 2 culture is required. For example, propionibacterium, for example, micrococcus. So many of our NICU cultures I have seen micrococcus has been reported. So, and the baby will be very stable, and coagulase negative staphylococci will be reported. So all these things are your commensal organisms. So in commensal organism, to give an importance to the commensal organism, 2 or more blood culture should be positive on a separate instance, obtained on a separate instance. Okay. And along with that, there should be at least one of the following. At least baby should be sick, there should be fever, hypothermia, there should be apnea or bradycardia. Just because the culture has come positive in an asymptomatic baby, you should not label it, and you should not give importance to it. There should be for a commensal organism, there should be positive culture and there should be some symptom also. For example, otherwise, if there is a pathogenic organism, you definitely have to treat. Okay. If there is Acinetobacter from the blood, even though the baby is stable, the baby may collapse anytime. So you have to give importance to that child. For a commensal organism, always give importance if there is 2 or more blood culture and the baby is positive. Okay. So when do you call it a central line associated bloodstream infection? All above criteria should be fulfilled, and there should be a central line. So there should be a central line for at least 2 days. Or the previous day you have removed the central line. The baby had central line, you would remove that day before, on the day or before day you have removed the central line, and that day you are sending culture. Then also you can call it as a CLABSI. Okay, so this is the definition for CLABSI. So once we know the CLABSI definition, we will see what are the organisms that can cause CLABSI. Okay. So incidence we have seen 11% in NICU patients, 25% in VLBW patients. And epidemiology, so as I told, it may be bacteria or virus, it may cause or fungus. All the 3 can cause bloodstream infection. Okay. So largest fraction is by cons. So that's why we have to be very careful when we are labeling cons as a bloodstream infection causing organism. It should be 2 cultures should be positive. What are the other agents after cons? Is second in rank is Staph aureus, Enterococci, gram-negative bacilli like E. coli, Klebsiella, pneumonia, Enterobacter, Pseudomonas aeruginosa. These are after cons. And then is Candida. So even viruses can cause healthcare-associated infection. For example, rotavirus can cause bloodstream infection, enterovirus, hepatitis A virus, adenovirus, influenza, RSV, HSV, parainfluenza. All these things outbreak can occur in NICU. Okay. And what are the bacteria that are responsible for pneumonia is your staphylococcal species are most common for pneumonia, whereas bloodstream infection, cons is most common cause for bloodstream infection. Okay, whereas pneumonia, it is staphylococcal species, and gram-negative organisms and Pseudomonas aeruginosa are other things, and fungi are responsible for systemic infections. Okay, those who are in prolonged hospitalization, only then this fungi can cause a role. Okay, and respiratory viruses outbreak can cause pneumonia, nosocomial pneumonia outbreaks. So both fungus, bacteria, and virus, all these three things can cause your nosocomial infection. So when these viruses usually occur during winter months, and for infected hospital staff, some of your staff may be having a cold, viral fever, and URTI. So in that time, it can cause nursery outbreak of RSV, parainfluenza, influenza, and adenovirus. There may be some hospital staff may be infected. So a causative organism, incidence, and why hospital-acquired infection, who are the patients that are prone for hospital-acquired infection. Okay. So this table is not required currently. So what is the pathogenesis of hospital-acquired infection or a nosocomial infection is, first is colonization. After that is entry into the bacteria. Colonization, where all colonization can occur? Colonization of skin, oropharynx, and GI tract can occur. Before any intrusion into the blood, so first colonization can occur. So this is most important step. If you prevent this colonization, you can prevent nosocomial infection. So that is very important. So all your prevention strategies should be aimed at preventing the colonization of the child. Okay. So premature infants, they are first exposed to pathogenic organisms from a parent or from a hospital environment. Okay, from your tape, infected tape, or touching the patient. Parents can be carriers of Staphylococcus aureus in their nasal mucosa. Okay, so they may get colonized by either Staph aureus or Candida or gram-negative bacteria and all these things. And they may, one other thing is indwelling devices, they may get colonized, and frequent contact with the contaminated medical equipment or an healthcare provider, hand of the healthcare provider. All these things will contribute to your pathogenic colonization. After colonization, the organism will enter the bloodstream. So how will it enter the bloodstream? Either through a breach in the skin or central venous catheter. For example, skin you are touching with an unsterile hand, and after that same skin you are pricking with a cannula. So the skin contaminant will go into the blood. Okay. How will the VAP occur? There will be oropharyngeal colonization, and subsequently it will get aspirated into the lower respiratory tract. This is the major route for VAP. Okay. So what are the two most important causes for healthcare associated infection? Lower gestational age and lower birth weight. Other risk factors are prolonged use of central venous catheters, umbilical catheters, broad spectrum antibiotics, and parenteral nutrition, and high nurse to patient ratio. There is only one nurse for 20 children. The nurse will not wash hands in between children. She will not follow the 5 important steps of hand hygiene. When to use hand hygiene. So she cannot be able to perform with such heavy load. Then there will be cross contamination between an infected patient to an uninfected patient. So these are the risk factors for your healthcare associated infection. Okay. So what are the types of infection? As I told, central line associated infection. Okay. So what are the complication of central line associated infection? 2 complications of central line. One is infection, another one is thrombosis. Infection we have already discussed, is CLABSI. CLABSI, what does it, definition already we know. Then what does it cause? It causes mortality, increased mortality around 4 to 20%, and increased length of hospital stay, increased length of mechanical ventilation, increased rate of BPD, increased rate of NEC, and increases the cost of hospital stay. Okay, these are the complications of CLABSI. Most common organism for CLABSI is cons. Half of the cases is cons. Apart from cons, as I told you, gram-negative bacteria, Staphylococcus aureus, and all these things are important. So what you should remember for cons is it should be identified from center line and also from a peripheral culture. If you are suspecting a cons, you should send a peripheral culture. As soon as you get a cons culture from a center line, always send a peripheral line culture. Okay. If both yield cons, then there is likelihood of true infection is very high. So when there is single culture, so only single culture is seen, then you should see the see the condition of the child. Whether the child is very sick, then you may have to treat the child with that culture positivity. Okay. So how do you, next is VAP, as I told. How does VAP occurs is, definition of VAP is very important. So you don't have a neonatal definition, only the infant definition. Less than 1 year, the same definition is seen. So if there is an underlying pulmonary disease or a cardiac disease, you should have 2 radiographs. Okay. So without underlying heart disease or pulmonary disease, only 1 X-ray is enough. Okay. So if there is an underlying pulmonary disease or a cardiac disease, 2 radiographs should be taken with a progressive infiltrate, cavitation, consolidation, or a pneumatocoel. If there is an underlying, already the child is having a pneumonia, child is having a BPD, there should be 2 radiographs showing serial worsening. Then only you have to label the child as ventilator-associated pneumonia. If the child is perfectly normal, just recently, first time the baby is intubated, okay, for apnea of prematurity, you have intubated, clear chest, then only 1 chest radiograph with above mentioned abnormality is enough. Okay. And second thing is there should be worsening of gas exchange. So there should be increased requirement of FiO2 requirement, increased pressure requirement on a ventilator. Suppose the baby is intubated today, after 2 days, there is increased ventilatory settings. Then this is your, you may be treating a VAP, ventilator associated pneumonia. On top of this, there any 3 of the following should be present. Out of the 6 things, 3 should be present. For example, temperature instability, WBC less than 4,000 or 15,000, new onset purulent sputum that is occurring during suction, and physical examination findings consistent with increased work of breathing or apnea, cough is there, and bradycardia is there or tachycardia is there. So out of this 6, any 3 should be there. There should be worsening of gas exchange and there should be an X-ray finding. How many X-ray findings? If there is underlying cardiac or pulmonary abnormality, 2 X-ray findings, serial X-ray findings. And if there is no cardiac abnormality, clear case, you are intubating, ventilating for some birth asphyxia child, there is no lung abnormality, only 1 chest radiograph has worsened, day 3 X-ray you have taken, you have put center line, you have taken X-ray that has shown worsening because ventilatory settings has increased, you have taken X-ray, that X-ray has shown increased infiltrates, then you can label it as VAP. Okay. And the baby should be at least on ventilator for more than 2 days. Then only you can label it as VAP. Not like on the day of ventilation, if there is infiltrates, you cannot label it as VAP. Or as I told, you should have extubated the baby on the day or day before. Okay. When you're labeling, then also you can label the baby as VAP. So VAP, how does it occur? As I told, colonization of oral mucosa, and subsequently there should be aspiration and subsequently worsening of gas exchange. Most common organism is, so gram-negative rods, Staphylococcus aureus and Enterococcus. So what is the most common source of VAP is oropharynx. Okay. So apart from that oropharynx, your contaminated ventilatory circuits or contaminated suction catheters can also cause your VAP. Other infections in hospital are skin and soft tissue infections. Skin and soft tissue infections usually occur after abrasion is there, or your frequent vascular access or surgical procedures you are doing, and the skin is very dirty and dirty dressings are there. So then it can cause skin and soft tissue infection. So both MSSA and MRSA are cause for skin and soft tissue infection. Sometimes gram-negative organism Candida can also occur after an intra-abdominal surgery. Okay. Next is invasive fungal infection. Invasive fungal infection more common in VLBW and ELBW infants. And first again, it requires colonization. Only it is common after first week of hospitalization. You don't usually suspect fungal infection after within first 3 days, 4 days. You don't suspect fungal infection. Only after you have given sufficient amount of broad spectrum antibiotics, there is prolonged hospitalization. So then only you see fungal infection. Especially it is more than 60%. If there is more than 1 month NICU stay, if there is sepsis after 1 month of NICU stay, always think of fungal infection. Most common organism is Candida albicans. Other things are Candida parasilosis, glabrata have also been seen. Okay. So what are the risk factors for fungal infection? Low gestational age, low birth weight are already known. Apart from that, more than 2 antibiotics use, H2 blocker use, prolonged parenteral nutrition, especially lipid you are giving, and poor enteral intake, and the complicated GI surgery you have done. Okay, so it has more mortality than bacterial infection. Mortality rates is more than 20%, and long-term developmental abnormalities is more than 50% in surviving infants. So what are the viral infections that can cause? Rotavirus. We have seen a lot of rotavirus cases as an NICU infection. It may cause encephalitis also. So how after the hospital acquired infection, how do you do prevention of hospital acquired infection? Most important step is hand hygiene. Hand hygiene is the most important intervention to prevent nosocomial infection. So lack of hand hygiene is one of the strongest correlation of nosocomial infection. And what does hand hygiene prevent is? It prevents colonization of hospital acquired infection. So what you should use is, you should know is hand washing technique, and also you can use is alcohol based hand sanitizers, and it is as effective as chlorhexidine containing soaps in decreasing the bacterial burden. You have to decrease the bacterial burden of your hands. Okay, so apart from that, is most important is time constraint and workload are the main barriers for hand care, and at least 15 seconds of hand hygiene should be followed. Okay, this may be asked in your Viva also. At least how much seconds you should do alcohol-based hand sanitizer. It is at least 15 seconds of hand sanitizer should be used. Okay. So next is CLABSI. How do you prevent this? You have to use care bundle approach. There are certain bundles for insertion and certain bundles for maintenance. Especially the hub of the center line, it has to be cleaned. There are certain precautions to do and insert center line, like skin disinfection, wear gown, barrier precaution, and there should be dedicated team to put center line. There should be checklists, and any nurse should be observing the center line procedure, and she should have power to stop the procedure. If there is a breach in the sterility, she should be empowered to stop the procedure. Anytime there is a breach, an observing nurse should be empowered to stop the procedure. Then there are bundles, aseptic technique approach, dressing changing protocols, and prompt removal of center line. Daily in your rounds, you should ask whether today center line is required or not. Today umbilical line is required or not. This should be your question, and it should be promptly removed. How do you prevent VAP? Is there are no further efficacious guidelines are there. Only thing to prevent VAP is you have to prevent the number of ventilation days. That is the most important part. And suctioning of oropharynx is very important. And your ventilatory circuit should not have a condensation. The water vapor should not be condensing in your ventilatory circuit. That may cause microaspirations, and that may cause atelectasis and ventilator associated pneumonia. And early feeding with milk. And antifungal prophylaxis is used in some centers where there is more fungal infection, especially in less than 1 kg babies. Okay. So these are some of the preventing steps. And then is nasal decolonization. You can decolonize Staphylococcus aureus. The nasal decontamination using mupirocin can be done. Okay. So these are the things. However, what they have seen in studies, if you nasal decontaminate with mupirocin, MRSA has been controlled, whereas there will be more of gram-negative infection. Okay, in those who have received mupirocin, there will be more of gram-negative infections that have caused because of nasal decolonization. Okay, so this is about hospital-acquired infection. So, any doubts you have with this? You read this chapter once before exam, because this is slightly a difficult topic for you to read and understand yourself. So I took this topic. Okay. So lastly, we'll discuss about neonatal transport. The other things we can discuss later on some other day. Okay, neonatal transport. This thing I have taken from NSSK, Navjat Shishu Suraksha Karyakram, recent to 2020 book. And also there is a chapter in Clarity also. Clarity gives extensively about considering the Western situation. Okay, so this is about neonatal transport, how they have to transport in Indian scenario, from a rural setting, from a PHC, from a small maternity hospital, How do you transport a sick neonate? They have discussed about this. Okay, so this is Navjat Shishu Suraksha Karyakram. This is not very advanced transport system, just a basic how does a transport setup for our Indian setting should be. Okay, so why do we need a neonatal transporters? The appropriate care during transport of a sick newborn to a newborn care unit, it improves survival, and also it will improve the outcome of the neonate. So how safely you transport the baby, it is going to decide the outcome of the baby. So many babies you have seen, the ET tube is out, the baby would have come in gasping state, you will not be able to salvage the baby. That is not going to result in any outcome. The baby must have transported, but it is an ineffective transport. That is not a fruitful transport. So that's why there should be a fruitful transport. So for a PHC, for a small center, which babies needs transportation is all babies who require positive pressure ventilation for more than 1 minute. So you should counsel any hospital who are only having a maternity setup. So many hospitals, they don't have an NICU. So many hospitals, they don't have any neonatologists going there. So you should all suggest them like which babies they require transportation. So all babies who require positive pressure ventilation more than 1 minute, that should be transported to an higher center. All sick babies, all LBW babies less than 1.8 kg. So more than 1.8 kg can be taken care at newborn stabilization unit. Okay, NBSUs. And all babies who are requiring orogastric feeds also requires a transportation according to your Navjat Shishu Suraksha Karyakram. Okay, so what are the components of transport is stabilization prior to transport, communication with parents and also to the unit where you are referring. There should be a maintenance of warm chain. There should be prevention of hypoglycemia, maintenance of airway and oxygenation, and what are the instructions to be given to the accompanying attendant or family members about the danger signs. So these are the components of your transport: stabilization prior to transport, communication with parents and the referral unit, maintenance of a warm chain, prevention of hypoglycemia, maintenance of airway and oxygenation, and instructions to the accompanying attendant, what they should observe during the transport. What are the danger signs they should look for the transport? Okay. So what are the equipments you need for transport is appropriate clothing for the baby. For example, cotton sheets, caps or woolen blanket. Thermometer is very essential. Cotton swabs, feeding tube, mucus sucker or suction catheter. There should be an oxygen cylinder, oxygen source, nasal prongs, resuscitation bag, pulse oximeter. Okay. If the baby is intubated, you need an extra endotracheal tube. Okay. What are the procedures? As I discussed, each component is slightly described. You have to describe each of the how many components? 6 components you have to discuss briefly. So stabilization prior transport is what you should do is you should warm the baby. You should see that the feet or hands are warm to touch, and you should position the baby and you should clear the airway. There should not be any secretions, and if required, you should oxygenate the baby. Okay, and you should give any pre-referral antibiotics or any pre-referral medications should be arranged. For example, during transport, adrenaline and all, and as per the doctor's advice, then medication should be prepared, a transportation kit should be prepared. Okay, then is the most important is communication. Whom you have to communicate? One to the family member and one to the referral hospital. You should communicate with the family regarding the condition, why you are transporting this baby, what is the reason you are transporting the baby to a higher center, what is the indication of transport. Okay, so you may refer the baby, and in between they may take to their home. Okay, they may not reach the referral hospital only. And you should communicate with the referral unit regarding what is the condition, what baby they are receiving. Suppose the consultant is finishing his duty by 7 p.m. and he is going, and some cardiologist is going, the baby may be PPHN baby, you may require cardiologist support. So if you inform the referral hospital, they may request the cardiologist to stay for 1 or 2 hours. So that will change the scenario when the baby reaches the referral hospital. And how much time your transport time you should inform, after how much time the baby is receiving. That is very important. In morning you may call that one baby is coming, and even till night 8 p.m. the baby has not reached. That is not done. Okay, and you should have a working diagnosis what you are suspecting, so that they will keep the equipments and the ventilator ready. Suppose there are no ventilators arranged in the referral hospital, the referring hospital can try to extubate a baby and make an arrangement of the ventilator. So these are all very minor things that make very important. And you should have a referral note, what has already been done to the baby and what medications have been given, and along with the dose and timing. Suppose the baby is having seizure, previously they have given phenobarbital 20, 10, 10, 40 mg per kg already has been done, and they have not written this. They have written only phenobarbital given. The baby comes to your hospital. You again load with the baby, start loading with the baby 20 mg per kg. Again, you give 10, again, you give 10, 40, 40, 80. The baby will not even wake up for next 1 week. Okay. So this may happen. This has happened many of the times with me also. Okay. And you have to explain the condition of the baby to the accompanying family members, and you should provide specific instruction to be followed in the route. Like if there are any secretions in the mouth, for example, tracheoesophageal fistula baby you're referring, you should ask them to keep the baby in lateral position. You should ask them to do suction every 10 minutes, 15 minutes when there is pooling of secretion. This simple technique, if you teach the attenders accompanying, that may save the baby. And you should, if there is apneas occurring, if, for example, the referral hospital has referred to you for recurrent apneas, you may ask them to gently stimulate the baby during any desaturations, and keep the baby in KMC as far as possible. And feeding, if they are long duration, you ask them to, you load a syringe with milk, ask them to give feed after 2 hours. Okay. And how do you prevent hypothermia is KMC. Okay. KMC is the best way to prevent hypothermia. If KMC is not possible, you have to remove the soiled nappy or linen. Warm clothing, you may warm the baby. Do not use hot water bottles. Never transport the baby with hot water bottles. That may cause burns to the baby, and that may cause legal issues also. If you're transporting any baby, never use hot water bottles to transfer. Okay. How do you prevent hypoglycemia? By giving feed, and instruct regarding feeding during transport. After 2 to 3 hours, you have to give feed. Okay. And ensure quick transport, and also prevent hypothermia. If you prevent hypothermia, there will be hypoglycemia will be prevented. Now, how do you prevent hypoxia? You should monitor the pulse oximeter, and you should position and clear airway if required, and consider use of nasal prongs during transport if there is less than 90%. And if the baby is apneic, ask them to how to stimulate the baby. Whenever the baby is going in for apnea, ask them, instruct them how do you stimulate the baby. Okay. So after this, you have to write this algorithm. Like, you should assess which baby needs transport to higher center. And like I told you, requirement of positive pressure ventilation more than 1 minute. All sick babies, all LBW babies less than 1.8 kg, all babies requiring orogastric feed. You have to prepare and organize the transport. You have to communicate whom to contact in the hospital when they reach, and inform the referral facility, contact person, phone number you can give. You have to arrange vehicle, you have to maintain equipments and drugs, and always allow the parents to see the baby during your transport. Don't just cover the baby, wrap the baby, so that you will not be able to see the chest movement, breathing. All this is not seen means there is high risk that the baby will die in transport. And always explain the clinical condition. Sometimes the child will come to your hospital, you will ask the attender history, why they sent. They will never be knowing anything. Why they sent? Because the doctor told to go, they will come. They said the baby came. So they don't know what is the condition. You don't even know the baby has a TEF, the baby has a CDH. They don't even know any condition at all. Okay. And so then you should consider maternal transfer also. Always try to send the baby. For example, if we are sending the baby for neonatal jaundice and exchange transfusion, if you don't send the maternal sample at least, then there will be difficulty in cross matching. And always obtain consent before transfer. Okay. And pre-treatment stabilization, this is the mnemonic you should remember. You should stabilize tops, temperature, oxygenation, and perfusion and sugar. Okay. So these are the things you should follow. And en route care is you should continuously monitor the baby, continuously maintain tops, and you should document all the actions that has been performed at your referral hospital, whichever you have sent. You should document all the steps, dosage, and once the baby reaches the hospital, there should be documentation should be done at the hospital. You have to document what vitals are there. This is for legal aspect, and you should hand over to the respectful person. You don't just drop at the main gate and then come back. Okay, this is all legal issues. Okay. So this is about transport, and what you can write is always you should always start whenever a neonatal transport is written. Always you should start with the opening line. It is always best transport is in utero transport. Okay, always in utero transport. You should, any sick baby you anticipate delivery, always try to transport mother and baby when the baby is still unborn. Okay, still not born, you should transport both mother and baby. In utero transfer is the best mode of transfer. Okay. And there are two types of transport teams are available. One is unit based hospital team, unit-based transport team. Then there is dedicated transport team. What is unit-based transport team is, for example, the unit which is treating the baby, the NICU unit, the NICU nurse, NICU doctor, NICU staff, NICU resident, they will go and pick up the baby and come, and they will only treat the baby. So this is unit-based transport team. Then there will be dedicated transport teams in Western population. The transport department only is separate. When there is high-level population transport occurring, then there will be dedicated transport team whose role is only transport. They will pick up the baby, they will drop the baby in NICU, and after that, the care of the baby is given by NICU team. So there is a dedicated transport team, and there is a unit-based transport team. So these two things you can add. This is given in priority extra. Okay. So this is about neonatal transport. So